Professor Paolo De Simone has been, chief of the Pisa Transplantation Center for a long time. Is a very renewed name in the field of liver transplantation. So is really the right one to start this webinar. Paolo, to you, please.
Thank you very much. Good afternoon, everybody. My presentation is gonna focus on indications for liver transplantation for patients with hepatocellular carcinoma and risk factors in the perioperative periods. And I'm very thrilled to deliver such a speech, such a presentation, because it allows me to introduce some of my personal opinions and viewpoints about this topic. First of all, I'd like to disclose my industrial connections in order to make it clear that I have some connections related with the speech. And here is basically, don't be scared. The outline, we'll go through this outline quite smoothly, I hope, in order just to tackle some of the intricacies and challenges and probably criticalities that we face currently whenever we have to deal with liver transplantation for hepatocellular carcinoma patients. The basic concept when talking about liver transplantation for hepatocellular carcinoma is that this is a formidable therapeutic option for these patients. And probably if we could compare the oncologic efficacy of liver transplantation for hepatocellular carcinoma to the oncological efficacy of other surgical treatments for other oncological disease, there would probably be no other, let's say, treatment with such an oncological efficacy range. But whenever we talk about, however, liver transplantation, we also have to bear in mind that liver transplantation is associated with a certain degree of complications, general complications, and complications related to the disease itself. One of the issues that probably is one of the most ominous is the problem of recurrences. However, I won't be talking about recurrences because recurrences do happen, and when they happen, generally, not always, but generally, they have a systemic or extra hepatic dissemination and involvement. So the scenario is very interesting and challenging. One of the basic concepts when talking about indications of liver transplantation for hepatocellular carcinoma is that currently most, if not all, of the algorithms, risk score models, or prioritization policies, institutional policies or regional policies or national policies or whatever, are generally based on the concept of tumor burden, the tumor mass, the presence of node metastasis, vascular invasion, and whatever. And this concept is at the very basis of either the, let's say, the two basic concepts of allocation algorithms. One is the BCLC, which is beyond the simple idea of liver transplantation. And the other idea that was generated by the Padua group, led by Umberto Cillo and Alessandro Vitale, is the well-renowned concept of the therapeutic hierarchy. But either concept, irrespective of the let's say, advantages or pitfalls hidden in either algorithm. Either concepts is based on the idea that generally, which is true, tumor burden, tumor mass, number of nodules, tumor size, or whatever, is basically the most important idea when designing treatment, deciding or focusing on treatment for given patients and on the treatment trajectory that we have to allocate our patients to. Now, my idea and my presentation, I would like just to lead you through a different trajectory, through a different, let's say, journey, just stating that along with the concept of tumor burden, currently our clinical experience and the literature is showing us that other biological, but also psychological, social, and societal characteristics or features should be, and risk factors should be taken into account in order to for patients' candidacy when to liver transplantation. There are some ideas that I would like to share with you. One concept is that there's an enormous gap in terms of sex or gender disparity in terms of the results for liver transplantation for hepatocellular carcinoma. And to this regard, the literature is quite consistent, just showing us that for multiple reasons, we were discussing with Professor Amadori a bit ahead of this presentation, but males fare worse than females for liver transplantation for hepatocellular carcinoma. This is consistently reproduced and debated and described in the literature for reasons that we clearly are not really entirely aware of. And here I have reproduced some slides from the literature just showing you that men, when compared with women, fare worse in terms of the overall results, but also in terms of the risk of hepatocellular carcinoma. And this is also true in publications stemming or originating from Europe, of the Western world, but also from Eastern countries, from Asia and from South Korea. So basically, the literature provides data about the fact that men are disadvantaged in terms of overall survival and disease-free survival when transplanted for hepatocellular carcinoma. The crucial point is that nobody, even in this roundtable, does not know exactly the reason why this is true, but this is true and consistently reported in the international literature. Another concept that should be probably incorporated in the indications for hepatocellular carcinoma and liver transplantation is the, again, well-renowned concept of frailty or fragility, as we used to call it probably a couple of decades ago. And we know, we have learned that frailty is an independent risk factor for worse outcomes after liver transplantation in general, for waiting list, because it is associated with a higher risk of dropouts from the wait list. It has been reported quite extensively in the literature, especially from the United States. Frailty is associated with a higher, which is to me a quite interesting concept, a higher healthcare utilization rate after liver transplantation, because these patients are more vulnerable, sicker than other patients. Frailty is associated, which is a concept very important for hepatocellular carcinoma, to a higher risk or proportion of failure of systemic therapy in non-transplant patients, but this concept can also be applied or transferred to transplantation. And in a multi-center study that we carried out along with the group in Rotterdam in the Netherlands, published a couple of years ago, enrolling other Italian groups, we could also demonstrate that frailty in terms of muscle mass is also associated with worse survival after liver transplantation for patients transplanted outside the Milan criteria. So there are biological features. The idea is that there are biological features related to the patient, to the tumor, that probably do impact or surely, undoubtedly impact on the prognosis, on the outcome of liver transplantation. One major issue is also the changing, it has been alluded to by Professor Cilla and Professor Ramadori ahead of this presentation, by the changing scenario of, or the setting of hepatocellular carcinoma, and this is the fatty liver epidemic. We are getting more and more aware of the intricacies, the inflammatory and the immunologic intricacies leading from the accumulation of triglycerides in the hepatocytes to development of hepatocellular carcinoma. And we know that fatty liver should be considered a particular immunologic and let's say inflammatory environment. So many considerations should be applied to liver transplantation just based on this basic idea. But we also know that obesity, fatty liver, is associated with different, with an impact with different immunologic response. For instance, obesity is associated with a reduced capacity of elicit an immune response, and this is probably due to changing in the phenotype of the tumor-associated macrophages. So there's a lot of data here just showing that fatty liver is a disease associated with inflammatory and immunologic changes. But we also have clinical evidence that patients with hepatocellular carcinoma in the setting of non-viral disease, which generally, but not necessarily, is metabolic disease, because we also have alcoholic related liver disease and disorders. Generally, and this is a paper from Eastern Asia, generally fare worse than hepatocellular carcinoma arising in the setting of viral disease. This is probably due to different, let's say, risk factors and the availability of antiviral treatment for viral disease. But there is the idea here in this slide that patients with hepatocellular carcinoma arising in the setting of fatty liver disease are a different entity and should be regarded as a different entity, and that the efficacy of the treatments available currently in our clinics is totally different, or can be quite radically different from the efficacy of treatments, considering, for instance, the impact of systemic treatments or immunotherapies for these patients. There's a further step that we also have to consider, which is the geographic variations in HCC epidemiology, but also the geographic variations in the access rate, in the capacity of people to access, to enter the treatment journey at home, in their region, in their countries. And some papers recently published have shown that barriers to liver transplantation do exist at a global level. They are probably different in developing versus developed countries, but they can impact considerably the outcome of hepatocellular carcinoma and liver transplantation. In this paper from the UK, from England, from the UK, but the survey was conducted in England, the proportion of patients, as you can read, receiving potentially curative treatments was different, was geographically segregated. In some areas, it was possible to provide patients with a higher proportion of curative treatments as compared to other areas within England, which is dramatic. So there are geographic disparities, even in, let's say, small regions, just like, or small country, like, for instance, England. In other countries, major countries with major experience in liver transplantation, for instance, this is Korea. The basic concept leading treatment is the one of tumor burden. But if you read this publication, you realize that even based on tumor burden, the percentage of patients allocated to liver transplantation, which in Korea means living donor liver transplantation, is very small. And as you can see here, is generally performed for more advanced BCLC cases or stages as compared, for instance, with Western countries. And we also know that the routes of the trajectories leading to treatment, to diagnosis and treatment, have an impact on the possibility and probability to be treated for hepatocellular carcinoma. And again, here in a study, in a recent study from England, from the UK, you can see here that patients referred to treatment by generally specialists or the general practitioners have a better outcome or probability to be treated than patients who are not referred to generally speaking by specialists, which opens up generally a dramatic problem about the right or the most important trajectory for liver transplantation. And again, here there are problems in the US. In a recent paper appeared this year, it was stated that there are regional variation in how MELD exception points are used in the US, and how this can impact the outcome after liver transplantation. Perioperatively, I would like simply to state that one of the major risk factors for worse outcome after liver transplantation is a surrogate marker, which is use of blood transfusions. Generally, we know that the higher the consumption of blood products during an operation, the more complex the operation and the worse the outcome. But I would also like to, let's say, state the case, just stating and inviting all the colleagues to be aware that use of autologous transfusions, other transfusions, or the intraoperative blood salvage does not have any impact on the recurrence of hepatocellular carcinoma after liver transplantation. And it has also been stated in a recent meta-analysis in the literature. Just wrapping up the presentation and coming up to the conclusion, when dealing with indications for liver transplantation for hepatocellular carcinoma, we do have several areas to be improved. These are quite different in developing versus developed countries. Probably it is my personal point of view. In developed countries, we have to focus on the right. This is a dynamic job. It is not something that can be easily done. On the right prioritization schemes to provide patients when talking about ALF, acute on chronic, or patients with hepatocellular carcinoma and compensated disease. We have the issues relating to the aging of the donor and patients' populations, and it will be handled further and more deeper in this webinar about the perfusion strategies and their impact on the outcome. Probably in our countries, in developed countries, focus is currently given and has to be given to the models to be adopted in order to better serve the interest of either cirrhotic patients or patients with hepatocellular carcinoma outside decompensated. It is not an easy job. It is not a cup of coffee. Whereas probably in developing countries where the incidence or prevalence of hepatocellular carcinoma is dramatically higher than the one in developed countries, the issue is just to implement the right liver transplant infrastructure in order to provide patients with the right and the most appropriate treatment. So my conclusion very, very simply is that currently all inclusion or nearly all inclusion criteria models and allocation algorithms prioritize tumor burden interpreted in different ways or fashions as the primary independent variable for weigh the risk of dropping out from the wait list, survival benefit, or transplant benefit. And this is scientifically sound. It is an important, relevant, and crucial principle. But the evidence is there that the results, the outcome of the liver transplant journey are very much related or influenced by patient-related variables, gender, condition-related variables, patient frailty, system-related variables, the access of patients, the routes to diagnosis and treatment. And the effort should be to incorporate all of these extra-tumoral variables in order to provide better indications for these patients with hepatocellular carcinoma. Thank you very much for your attention.
Thanks a lot, Paolo. Really thanks. I think that is important for all the attendee to clarify that we are, of course, open to any question, and you can do directly or just, typing in the dedicated section. So I don't know if Giuliano wants to add something or ask a question. Please go ahead.
I first want to thank Paolo for the great talk. He just showed how big the topic is. So we could discuss for days about all these points, but I have two let's say, comments. The MELD score, the match MELD, favorize the HCC. It does not favorize the decompensated cirrhosis. So starting with 22 points at any stage, it gives a really big advantage to the HCC patient. But my question is, how is the in-hospital mortality of a transplanted patient? Is this for HCC different than patients for decompensated cirrhosis or not? In-hospital mortality.
Well, generally, based on my experience, it is not higher, irrespective of the fact that we are using more marginal organs, especially for advanced hepatocellular carcinoma patients. And this is due to better selection criteria of our donors and recipients, to the fact that generally we tend to eliminate some biases in patient selection. For instance, what I mean is generally we tend to exclude patients with high or dramatically elevated alpha-fetoproteins. And thanks to the use of currently perfusion strategies that are enhancing the results of liver transplantation for marginal donors. So generally speaking, no, they are not different. A patient with hepatocellular carcinoma can be burdensome when the degree of liver decompensation and cirrhosis is important, is severe when the patient is sick. There's a proportion of patients with hepatocellular carcinoma that are currently unserved by or not appropriately served, in my opinion, by current treatment modalities, which are patients beyond Milan criteria with decompensated cirrhosis. These are patients who are not available, for who there's no available, or let's say, ideal treatments, systemic or radiologic or even transplantation, that can be probably used.
Yeah, if I can integrate Paolo's point of view, which is very important, it's very important to give the right perception of which is the postoperative mortality of liver transplantation. Now, in high volume center, hepatocellular carcinoma has a very, I would say, significantly lower expected postoperative mortality. Why? Because we have machine perfusion. It's true that we use marginal donors, but we have machine perfusion, which equalize the risks. And on the other side, the hepatitis C burden is clearly zero, basically much reduced. So we have much less decompensated patients. So in the end, we probably stay below 4% postoperatively. I think it's a very important message to give.